Okay. This will be an adult case. Gunshot wound to the left upper back. So this is directly from the run sheet. It says, on arrival, found patient sitting upright outside home, patient obvious respiratory distress, unable to answer questions, patient complains of difficulty breathing, and pain in chest. So on arrival to our trauma bay, so we've got a 42-year-old male with gunshot wound to the left upper back. And a left-sided needle thoracostomy had been performed in the field for diminished breath sounds on the left. And this is what the patient looks like. We've got patent airway. There's still decreased breath sounds on the left. Heart rate's 112, respiratory rate's 22. Blood pressure is 144 over 119. GCS is 14 because the patient's confused. And obviously dyspneic. So here's the survey questions. So just a reminder, you text 22333 and then choosing A, B, C, D, or E, just enter the number. Do not enter STACS in front of it for these ones. So choices, we can go ahead and intubate. We can go ahead and immediately place a left chest tube. We could see what's going on with an X-ray. Thank you. We can examine wounds, or we can get a CT scan of the head for this GCS of 14. So let's take a look at your choices. Okay, so the majority of the room is pretty smarter than we were, but let's go ahead here. So, we're worried maybe about tension physiology here, or certainly enough a significant pneumothorax on the left, or possibly a hemothorax on the left. So going ahead and placing the chest tube without an X-ray may have been a good idea. We didn't. We got an X-ray. Sometimes the X-ray happens before the patient gets there, it feels like. So you can see that there is a pneumothorax there. I don't know how well that projects. So the arrow's there. And there's a little bit of shift of the trachea and the heart itself. So ideally, for this sort of scenario, first chest tube, then intubation. Because if you have a tension pneumothorax or a massive hemothorax, you want to go ahead and treat that immediately. It's immediately life-threatening. And if you intubate first, you may actually cause the patient to completely decompensate. So better to do the chest tube first, and that's often tested on ATLS questions and the like. So we did get the patient intubated and get a left chest tube in, and then where our vitals were better, heart rate 87, blood pressure, he has a little bit of hypertension, 174 over 114. And then this is kind of what the secondary survey looks like. So we've got a single wound to the left upper back, and then you could actually palpate a foreign body, which was presumed to be the bullet, in the right supraclavicular fossa, so just above the collarbone on the right. And so this is what the X-ray looks like now. So you can see that's the marker on the back. It's a little displaced. It was really right over the scapula, but that's how it looks on the X-ray. And then you can see the bullet up here. And no more pneumothorax with the chest tube on the left and endotracheal tube in place. So now what do we do with the patient? We can go to the ICU and just vent wean, chest tube management. We can do a CT of the chest and neck, maybe endoscopy, tracheoscopy, and or esophagoscopy, or do both CT chest and neck and some endoscopy, or just go straight to the OR. Nobody's in a rush to go to the OR. Okay. All right, so what we have here is a transmediastinal, perhaps transcervical gunshot wound. You can see the trajectory there. And so really we have to worry about what's in the mediastinum. And we've got major vascular structures to worry about. We've got the tracheobronchial tree and the esophagus. So it really mandates that we rule out these injuries or injuries to these structures. So we want to get, generally in today's day and age, CT angio of the chest and neck is usually the first line. And then you do want to rule out an airway or a digestive injury with tracheoscopy and esophagoscopy, plus minus doing an esophagram. So, just to review our CT imaging first. So we went to CT, the patient was stable. And so here you can see that there's some fragmentation of the anterior T1 and T2 vertebral bodies. And a little bit of pneumomediastinum. And some apical pulmonary hemorrhage on the right side. So following CT, we took a look in the trachea with a bronchoscope, and there was no injury to the trachea. There was some erythema there, but nothing to suggest any full thickness injury. On the esophagoscopy, which is pictured here, and it's hard to see in this picture, but that's why the arrows are there, there was a through and through esophageal injury at 21 centimeters from the incisors. So now, what do we do? So we can try and fix it going through a cervical approach. We can try and fix it going through a thoracotomy. Get IR to place a drain there. Just treat the patient with antibiotics and nothing by mouth. Or maybe put a stent in. Okay, so treating it with a stent's a pretty popular idea. Well, let's talk about what you might do in the operating room first. So the principles of fixing a hole in the esophagus is getting to it early, closing it, and then often, if you can, get tissue coverage over it by mobilizing some muscle over the repair and making sure you've got drainage, so if it does leak, it's going to leak in a controlled fashion. In this case, though, I'll remind you the bullet trajectory is right there. The question is, how would you expose this? Because it's in a difficult spot. It's right at the thoracic inlet. So you could try and go through the neck down into the thoracic inlet, or do a high thoracotomy and kind of go upwards, or maybe do both. It's not easy. So we phoned a friend. And we got our thoracic surgery colleagues involved. And they had quite a different idea. So they actually started with taking the patient to the operating room and started with VATS. The patient had a well-placed chest tube on the left already. And what they did on the right was they put a scope in. There was a hematoma at the apex, which they opened and evacuated, and then placed a chest tube up there. And then immediately they flipped the patient supine and placed a stent. So that's a picture of the stent, and the stent was deployed along with a nasogastric tube and nasoenteric feeding tube. And you can see here, this is the post-stent placement X-ray. You can see the chest tube on the right, and you can see the mesh part of the stent there in the middle. So, what happened next? So the patient went to the ICU, was able to be extubated the next day, and had nothing to eat or drink, was just supported nutritionally via the nasoenteric tube, and IV antibiotics were continued. There was felt that the stent had moved a little bit, so the patient was taken back to the endo suite on postoperative day 5, and they also wanted to look at the trachea again to make sure that nothing had progressed to a full thickness injury from what was seen before. And that looked okay, and the stent was repositioned. And then the question is, okay, so how long do you need to leave the stent in? So the thoracic surgeons felt that 10 days is probably enough. So they checked on it. But it looked like it had not really fully healed, and the stent positioning wasn't great either. It was causing some erosion. So they put in a new stent. And then 4 days later, took a look again and felt that things had healed enough so we could remove the stent. And then we fed the patient and was able to discharge them home shortly thereafter. And so this is what the esophagus looked like after final stent removal. So no sign of any injuries really that I can tell. So some remarks. So, penetrating esophageal injuries are pretty rare. It's a pretty skinny little organ. When they're situated at the thoracic inlet, they're particularly troublesome because they're hard to get to. So if we had done an operation on this guy, it probably would have been quite a significant extensile exposure. Non-operative management can be an option if you determine on esophagram that you've got a very small and contained leak. You can manage that patient with NPO and antibiotics. Generally, though, a through and through gunshot wound, it's often not suited for that. Interestingly, there's been very little, if any, reported experience with stenting the esophagus for trauma. But in the last 10 years, there's been a fair amount of experience with it for non-traumatic perforations. So spontaneous perforations or post-esophagectomy anastomotic leaks or a iatrogenic perforation from an NG tube or something like that. And this has been largely effective with overall success rates reported of 81 to 91% and low incidence of complications. So I think what this case does is it really highlights the potential benefit of using a stent for penetrating esophageal trauma, namely a gunshot wound. This patient was saved a potentially morbid surgical incision or incisions, and avoided the potential complications after that procedure of suture line breakdown and formation of fistula. So I think his experience with endoscopic stent placement for this type of problem grows. It's imaginable, particularly for these isolated type injuries, that it could become the first line management for these types of injuries. Thank you.